the pulmonary system. This will be a lecture in two parts. We're going to start off with normal anatomy and physiology. And this is showing the normal respiratory system, starting at the mouth and nose and going all the way through to the alveoli. And here are your alveolar sacs with the respiratory bronchioles. Intrapleural pressure is always negative. That negative pressure is what helps to keep the lungs inflated, because we keep taking breaths in to equalize the pressure. Your diaphragm does 80% of your breathing, and it is innervated by the phrenic nerve, which is a branch of your fourth cranial nerve. Your spinal cord damage at the level of C3 to C5 will alter your breathing, and if there's damage above level C3, it'll stop your respiration, so you will not breathe at all. Exhalation in and of itself is passive, and on expiration the diaphragm becomes an accessory muscle. Your accessory muscles, in case you don't remember because we talk about them all the time, are your scalene and sternocleidomastoid muscles. And your intercostals can be a little bit. So, on inspiration, the intrathoracic pressure is 752 millimeters of mercury. Your intrapulmonary pressure is 758, and atmospheric pressure is 760. So, you'll breathe in. When you breathe out, diaphragm comes back up, and the pressures change. Your intrapulmonic pressure that's 760, atmospheric of 760, intrathoracic of 755. Pushes the air back out. So, the purpose of your upper airways are to warm, humidify, and filter the air. When you lose your upper airways, your nose and your mouth, that piece is gone. So if you have somebody who is ventilated, intubated and on a ventilator, or trached and on a ventilator, or trached permanently, they lose that warmth, humidity, and filtering capabilities. And we need to provide that to them some other way. Your trachea is located below the level of the angle of Louis. It's at the level of the fifth thoracic vertebrae. The bronchus to the bronchioles are considered dead space. Actually, from your nose all the way to the bronchioles are dead space. Now, in dead space, there is no effective gas exchange at all. The terminal bronchioles will allow for some minimal gas exchange. Not a lot, but a little bit. So it's not considered part of the dead space. That dead space is usually about 150 milliliters. Your defense mechanisms for the respiratory system, the first is your mucus. We produce about 100 milliliters of mucus a day. This will trap the foreign bodies that are there. And then the cilia will move those trapped particles toward the nose and the mouth. Cough is always considered protective. If it's productive, it's protective. When it's not productive, it becomes a hassle. And that's another issue. But normally it's productive. Now, of the mucus that we produce, that 100 milliliters, all but 10 milliliters of that is reabsorbed. So your patient should only be coughing out totally a day, 10 milliliters. And you want them to cough it out, not swallow it. Because when you swallow that mucus, it goes into your stomach. Think of your chronic lung patients. What do? First thing in the morning, they have lots of mucus, they cough it up to the back of their throat, and swallow it. Now, they overproduce mucus, got lots of mucus in their stomach. Breakfast comes. Are they hungry? No, because their stomach is full of mucus. So we need to make sure that they cough this out. It's much better for them. And then we also have alveolar macrophages. Now, macrophages will phagocytize or eat the particles in the alveoli that the cilia aren't able to move up, and they get the rest of the way down. And this is showing a diagram where you can see when somebody's standing upright how the mucus evenly lines the whole bronchial system. But when they lay down, it becomes redistributes itself. And you can see that the opening when you're upright is much wider than the opening when you're lying flat. Your alveoli. are the major site of gas exchange, and we have over 300 million alveoli. There are two types of cells. Your type 1 cells allow the air to bypass a blocked alveoli through the collateral air passages. They're very sensitive to toxins. Your type 2 produce surfactant. Now, surfactant is necessary to decrease surface tension so the alveoli can expand easier without a lot of work, and as a result it decreases the workload of the work of breathing. And because it decreases the work of breathing and you can expand those alveoli, you expand your chest wall, and that increases compliance. Because if you remember, compliance is the ability of the lungs to expand. It doesn't talk about recoil, it talks only about expansion. Now, when we give somebody supplemental oxygen, it's important to know what the flow rate is that we're giving. What is the amount of oxygen in the room? Hopefully you said 21%, because in this area it's 21%. Now if you're living in Pittsburgh, Pennsylvania with all the steel mills, that percentage is a little bit lower, which is one reason they're showing on the news, I just heard it the other day, that if you're in an area of a lot of air pollution, the fetus in a pregnant woman can be born with less intelligence. They're not mentally retarded by any means, but their IQ will be lower by 4 to 5 points, they were saying. That could be significant with repeated generations, so it is something that they will be studying. But in Ohio, nice flat Ohio, here around Toledo, not a lot of steel mills, the percentage of oxygen is 21%. So when you put them on a nasal cannula, and you put it at 1 liter, it's 24%. So you add 3 points, 3%. Thereafter, for every one, you add 4%. So if you're doing it at 4 liters, it's 36, 5 liters is 40%, and 6 liters is 44%. Anytime you're at 4 liters or greater, you have to humidify it, because oxygen is very, very drying. Please remember it's also a drug, and you need a physician's order for it, unless you're working on a unit that has standing orders that allow you to do that, but then you still need to tell the physician that you started this. If you need to infuse oxygen at higher concentrations than 44%, you want to use a face mask. 5 to 6 liters, 40%, 6 to 7 liters, 50%, 7 to 8 liters, 60%. They have a new way of giving oxygen, and it's called a vapotherm unit, and they can use vapotherm, which is a type of humidified oxygen that's given at the bedside, up to 100% at the bedside by using a nasal cannula. So that's still being investigated in many places, but it was being used, I know, at the Toledo Hospital. So you may see that kind of unit used more often in the future. Some of the terms that go along with the respiratory system when we're talking about it, one is tidal volume. And tidal volume takes in the amount of air that you breathe in and breathe out. It's your total quantity in and out. Your inspiratory reserve volume is that which you can breathe in over and above what you normally do. And your expiratory reserve volume is that which you breathe out over and above what you normally do. Now, normally, you would like ventilation to equal perfusion, and it doesn't exactly, because what you breathe in is about 4 liters a minute. But what you circulate is about 5 liters a minute. Now, normally when you write, you use V for ventilation and Q for perfusion. I really don't know why they use the Q, but they do. And usually that Q will have a little dot over the top of it. But I could not find that symbol on the computer, so you're stuck with just a plain old Q. So that your ventilation to perfusion ratio is 4 to 5, or 0.8. Keep in mind that gravity will alter your ventilation. You're better able to breathe in if you're standing up with your shoulders back, feet flat on the floor, than when you are lying flat on the bed. Lying flat on the bed, it's a little bit harder to get that oxygen in as much as you were getting. And oxygen at the bases is always greater than at the apex. Now, oops, I'm going back one. Come on, let's go back. Your pulmonary vessels will constrict if your PaO2 is less than 60%. Everywhere else in the body, your blood vessels dilate, but in the lungs, they will constrict. That's why your patients who have chronic lung disease, COPD, emphysema, develop pulmonary hypertension, because when their PaO2 level drops below 60, your pulmonary vessels constrict, makes it harder to pump that blood from the right side of the heart to the lungs, increases right atrial hypertrophy, right ventricular hypertrophy, can send your patient into cor pulmonale. And I know you remember all of that from patho. It was just last semester. But in case you don't remember, I just reminded you.
And you taught that?
Your control of respirations. Your brainstem is automatic. You have your medulla that maintains the rhythm of your breathing, and the pons that does the rate and the pattern of respirations. It will stop your inhalation, and it also controls the depth of the respirations. Your cerebral cortex is your voluntary control. This is necessary if you start to laugh. You need to be able to take another breath, because sometimes you laugh so hard you can't get a breath in. And your cerebral cortex takes over and says, take a breath. Or if you sneeze a lot, or things like this. Your central chemoreceptors sense changes in your hydrogen ion concentration and in your PaCO2. Now, they're central chemoreceptors, so they're located near the medulla. They're central to the brain. They sense your PaCO2 that's in the cerebral spinal fluid. It'll increase your hydrogen ion concentration. That will increase your respirations. And this is a long-term effect. So this takes quite a while for this to take effect. Now, your peripheral chemoreceptors that are peripheral to the brain are located near your aortic arch and in your common carotids. And they will sense changes in your oxygen first, and then in your PaCO2. So they'll sense a decreased PaO2, which will cause your body to increase ventilations to get more oxygen in, and that, or if you then increase PaCO2, it'll increase ventilations. So over time, the body becomes less sensitive to changes in oxygen. And if you have somebody who has chronic obstructive lung disease, and you give them too high a flow of oxygen, they just won't breathe, because they won't see the need to do that. That's why we limit the amount of O2 flow that we give to our chronic lung patients. We also have irritant receptors that are necessary so that if we breathe in a fly, we'll cough it out. We have stretch receptors that protect the lungs against overinflation, so that you just don't keep breathing in until the alveoli go boom. Your PaO2 is the amount of oxygen dissolved in plasma. This is 3% of the total. This is what is available for the cells to use. Your SaO2 is the amount that's bound to hemoglobin. This is the majority of the oxygen, because each hemoglobin molecule can carry 4 oxygen molecules. So that's why that has the majority. And this tends to stay in an equilibrium. You tend to keep your PaO2 between 80 and 100. And when it drops below 80, more will be released from the SaO2. So the other thing to keep in mind is when you do your pulse ox, you're doing your SaO2. You're checking the amount of oxygen that's available for the tissues to use when it's not in equilibrium any longer. And remember, if your hemoglobin is low, you could still have 100% SaO2, but that doesn't mean that your cells have the tissue. Your tissues have the oxygen available to be used, because if you're anemic, you don't have enough red blood cells to transport that oxygen. So, decreased oxygen carrying capacity of the hemoglobin occurs, as I've mentioned, with anemia because you have a decrease in hemoglobin. If you have a hemoglobin S, and this occurs if you have sickle cell disease, this will, because your hemoglobin S has a decreased affinity for the hemoglobin, and so it has a decreased affinity for the oxygen, so it doesn't transport as much oxygen as a regular hemoglobin does. That's oftentimes why the patient with sickle cell anemia will go into crisis, because they don't have enough oxygen circulating. Carbon monoxide and iron, iron is called methemoglobin. Carbon monoxide and iron have an increased affinity for the hemoglobin, so they don't allow any oxygen on it. And you get somebody who's very, very ruddy looking and yet not doing well because they don't have enough oxygen to the tissues. And that's why they put these people in the hyperbaric units. And the ones, of course, that are greatest risk are our firemen. When you have somebody who comes into you with a respiratory problem, you have to do a history. That history includes their risk factors. Do they smoke? Are they homeless? Are they immunosuppressed? Are there any genetic factors that may lead to this disorder? Are they living in crowded conditions? Do they have 33 people in a 3-bedroom apartment? What medications are they taking? Pardon me. What's their occupation? Their living conditions. Any allergies? That sort of thing. Then you start to inspect your patient. And if you're doing a good job, you're inspecting them while you're getting the history. But you want to look in the tongue and in the sublingual area. You're looking for central cyanosis. Central cyanosis means that you're not getting enough oxygen in. Peripheral cyanosis is when you look at the fingers and toes. This means you're not getting enough oxygen circulating. So peripheral cyanosis is more of a cardiovascular problem. Central cyanosis is more of a problem with the respiratory system. You need to assess their chest wall configuration. Pectus excavatum is a funnel chest. In other words, you have a narrow anterior-posterior diameter, and if you were to look at the chest, it would look like a bowl. In fact, I was watching Jay Leno at night sometime when I didn't have to go to school, and there was this college student on there who ate some cereal out of his chest because he had pectus excavatum, and they did that on national TV. Pectus carinatum is a pigeon breast. This is when you have an increase in your anterior-posterior diameter. A barrel chest, think about all your chronic lung patients. Over time, as the air keeps getting trapped in the lungs, the rib cage is not able to return to its norm, its baseline, and so you end up with a barrel chest. And spinal deformities make a big difference, whether you have kyphosis, lordosis, or scoliosis. Now just for a moment, sit there, put your feet on the floor, and then twist to the side and lean forward. You now have somebody with kyphoscoliosis. Take a deep breath in. Were you able to? Were you able to take as much in if you sat up? It's that simple. You don't allow the lungs to expand appropriately. You need to assess their respiratory effort. Now, normal respirations are 12 to 20. I don't care if you have COPD, normal is still 12 to 20. Now, if you have somebody who has COPD, their baseline is probably 24 or 26. That's the norm for them. But that's not normal. That's tachypnea. Hyperventilation is where you have an increased rate and depth. For tachypnea, you tend to have just the increased rate, but with a decreased depth. Are they using their accessory muscles? And those are? Look at their nose. Do their nares flare when they take a deep breath in? Are there intercostal retractions? Is there unequal chest movement? Now, unequal chest movement tends to occur if you have somebody who has a pneumothorax, or for some reason one lung is not expanded as well. Is there tracheal deviation? That will help you identify what the problem is, because the trachea should be midline. Are there any tubes? Do they have an endotracheal tube in place? A central line? Chest tubes? What sort of things are there? Then we're going to start palpating. You palpate the position of the trachea. As I said, normally it is midline. It will deviate if you have a pneumothorax, because it will deviate to the opposite side of the pneumo. After all, the pressure will be shifting to the opposite way. Pneumonia, opposite side. Fibrosis, atelectasis will be toward the side of the problem. And pleural effusion varies because it depends on where the effusion is located. You need to assess thoracic expansion. Is it symmetrical? It should be. If it's asymmetric, you may have either pneumonia or a pneumothorax. In order to assess expansion, you want to put your hands on the chest on both sides. And I find it easiest if you put them like on the back near the spinal cord and have them take a deep breath in. You should then be able to see that your thumbs move apart in equal portion. They should separate 3 to 5 centimeters on deep inspiration. Then you want to check tactile fremitus. Now, tactile fremitus is when you put your palms on your chest and you have the patient say 99. Normally, over the trachea, peripherally, it will be decreased. So lower down, it'll be decreased because the sound won't be as loud. Makes sense. It's decreased with pleural effusion, bronchial obstruction, a pneumothorax, emphysema. It's increased with pneumonia, cancer, and fibrosis because your cancer, fibrosis, and your pneumonia tend to consolidate the tissue, and so it tends to be a little bit louder. You then want to percuss. Again, you're looking for diaphragmatic excursion, so you find the diaphragm and you mark it. Then you have them take a deep breath in, and you should see that diaphragm drop 3 to 5 centimeters, and then come back up when they breathe. So you check for it on inspiration and expiration, and again, it's a way to assess for equal movement. Auscultation is when you listen for abnormal breath sounds. It's very abnormal not to have breath sounds. So absent breath sounds are extremely abnormal. Diminished breath sounds happen often, particularly initially if you have somebody who has air trapped, somebody with chronic lung disease. Displaced breath sounds are when you have bronchial sounds in the periphery rather than over the trachea where you expect to hear them. Displaced breath sounds tend to occur if there's fluid or exudate in that area. Adventitious breath sounds are crackles. Now I know everybody calls them rails, but the real term is crackles. And crackles tend to be louder on inspiration than they are on expiration. They're fine, medium, or coarse. They identify fluid. So if you hear crackles on somebody, that means they have fluid in their alveoli. And when they get lots of crackles there, they're breathing underwater. Not a good thing. Rhonchi means that you have something in your major airways, in the bronchial, the trachea, bronchi, somewhere there. They tend to be louder on expiration. They should clear with a cough. So you should have them take a deep breath in and cough, and they should either decrease or totally go away. You always want your patient, when you teach them to cough, by the way, is to take like 3 deep breaths in, and on the 3rd breath, cough out, because then they'll have a nice deep cough. Otherwise, they'll be going and you're not moving anything. So you want to take a nice deep breath in. A wheeze is a musical sound. It's like a don't ask me to do that again. But it means that you have narrowing. And it can be either on inspiration or expiration. But you have a problem with a very narrowed bronchial tree then. A friction rub, again, just like for the cardiac system, is like the sound of 2 pieces of leather rubbing together. But you'll notice that it occurs with the respirations, not with cardiac. And if you're having trouble telling whether it's a pleural friction rub or a pericardial friction rub, ask them to hold their breath. If it goes away, it's pleural. If it doesn't go away, it's pericardial. And just as an aside, don't ever tell your patient to stop breathing. They might take you up on it. When I worked in critical care, it's routine that you would get a chest x-ray on your patient every day to make sure the tube's still in good place and there's no pneumonia or anything else going on. And we had a radiology tech who would come up and yell at the patient, "Stop breathing." These people were on vents. Or, if they weren't on vents, they may actually take him up on it and stop breathing. Then it's the nurse. I got a lot of work to do. I don't like that. I finally convinced him to say, "Hold your breath." Took 3 more words, but it really made me feel a whole lot better when he said, "Hold your breath," rather than "stop breathing." There are voice sounds that you can use to identify lung consolidation or lung compression. So if you have a tumor, pneumonia, that sort of thing. There are different types. Bronchophony is when you have them say 99. I don't know about you, but every time I put a stethoscope in my ears to listen to a patient, they start talking. Can you understand what they're saying to you? I cannot, unless they have a problem. Because normally when somebody says something, you don't hear it. If they have bronchophony, you will understand it with the stethoscope. Okay, it'll increase in intensity and clarity. Whispering pectoriloquy is when you have them whisper 1, 2, 3, which normally you would not understand when you listen with a stethoscope. But if they have whispering pectoriloquy and you listen, you will hear them say 1, 2, 3 when they whisper. Egophony is when you have them say E, 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 and it sounds like A. A. And this is where we're going to finish part 1, and we'll start part 2 with your pulmonary diagnostic procedures.